welcome everybody to this symposium on community engagement in vector-borne control, vector-borne disease control. I am very honored to chair this session, and we have a wonderful group of speakers today. We have Kevin Pardosh, we have Cohen Peters, and we have Mariana Santamartino, and I am thrilled that we're gonna get to hear their presentations. But to get things going, I'm gonna get us started by presenting some of the work that we have been doing in Ecuador. And could you please confirm that you can see my my screen?
Yes, we can.
Wonderful. So vector-borne control is about, of course, controlling the vectors. But what I wanted to talk about today was the need to understand the whole picture. How we need to approach vector-borne disease control from a multidisciplinary, with a multidisciplinary approach. And to exemplify this, I'm gonna discuss some of the work that we have been doing in Ecuador over the last 15 years or so. And I wanna acknowledge my collaborators, Majo Carrasco and Carolina Herrera, who helped me put together this presentation. So we all know Trypanosoma cruzi and what it does to so many millions of people around the world, especially in Latin America. And we also know that it is mainly transmitted by the kissing bugs, the vinchucas, the triatomins, the chinchorros in Ecuador, pitos, you name it. But what is very common about the vector transmission of Trypanosoma cruzi is that it is associated with precarious living conditions. With the many species that we have of bugs, the commonality is that they all seek blood and they all look for opportunities for food and reproduction. And environments such as these in southern Ecuador provide an excellent scenario for the kissing bugs to thrive. And we have been hearing a lot during the last couple of days about high-level research and basic and applied research that have to do with the understanding the biology, understanding how vector-borne diseases can be controlled, mosquito populations control, and so on and so forth. But until we find a way to prevent people from living in environments such as this, Chagas disease and many of the vector-borne diseases that we study will continue. There is no two way around it. And the current methods that are recommended for vector-borne control and that have been largely successful in the many areas like the southern cone of South America to control Triatoma infestans, and in Central America to control Rhodnius prolixus, they have met their barriers. We cannot do the types of things that were done there and have the same results in environments where these species of triatomins are sylvatic, like the Chaco region, like Ecuadorian, most of the Ecuadorian range, where we have these wild populations of triatomins. So the question is, in the absence of an ability of governments, and I now refer particularly of Ecuador, to maintain insecticide-based control program, what can be done to prevent transmission? So over the last 15 years, we have been working in this in this area. This is the southern area of Ecuador. This is the city of Cariamanga, a beautiful region. Here is the Ahuaca mountain next to it. And the communities that we work with are located in this sector over here. We chose this area because our vector surveillance research determined that this area was one of the hotspots of triatomine infestations in the houses. And when we started then, there was this question about how to do things differently. Because just giving the government the prevalence or incidence, just complaining about the lack of access, just trying to speak to anybody that would listen about Chagas disease really wasn't cutting it for us. So this led to the development of a relationship with these communities, of a way to use this as a learning hub that could inform future larger intervention for this region and perhaps elsewhere. This was done and will continue to be done within the framework of the Eco Health, the Sustainable Development Goals, the One Health, and trying to base our work in the strengthening of local organizations via the recruitment and participation of international partnerships. So our initiative has three main components that were developed along with the community: health, infrastructure, and income generation. And now that I look back to what has been done in the last 15 years, I ask Majo and Carolina to make a detailed list of the projects that we have been doing. And so there are about 80 projects that have been carried out. Among them, 19 health projects, 20 income generation projects, 7 infrastructure projects, 4 that can be cataloged as health and income generation, 1 of income generation and infrastructure, 14 of infrastructure and health, and about 14 other projects with social change. Now, this is a large body of information and a large amount of work that has been conducted. So I have chosen a few of these sort of to exemplify the multidisciplinarity of this work. Starting with what the community told us was their first need. When we approached, my charter to my team was, we don't come here as experts, we come here as learners. And the first thing that the community manifested was that they did not have drinking water. And that was the foremost preoccupation that they have. So we started working with local NGOs, and finally by 2012, we were able to help the community build the first drinking water project. And this was chlorinated water from a source far away. And it was this process of working with the community in something that was their primary concern that really gave hold to the project and provide us with the entry to everything else that came after this. Because communities are, and especially rural communities in general, very skeptical about foreigners, especially because, you know, people come dangling, politicians come dangling promises. People have seen so many transit projects that come, take away, and never come back, or promise and never deliver. So by working with the community members so that they are the ones in charge of their water project, we were able to build this rapport and this trust with them. Another interesting thing was this work that was led by Claudia Nieto, now working with Cohen in ITM, and is the use of positive deviance in designing and introducing a housing model to control Chagas disease. We knew from the get-go that building houses was going to be a long, protracted process, but what to do with the people right there and then. So we had longitudinal entomological information, and we were able to use this information to determine which homes never had bugs, and then go there and look at what they were doing already. And those practices are easy to replicate, and they are being replicated. For example, they use in the winter months, there is these plants, they call them plantas amargas, or sour plants. And these are natural insecticides. So they sweep their homes with that, and that protects them from bugs, of all, insects from all kinds, from cockroaches to fleas to everything else, as an example. We continue working in trying to understand what would it take to change the housing here. So through this project, we collected data about the climate on the communities for the introduction of housing improvements, as a protective measure. Have the communities reached a point where they could think about something else than their everyday struggle and look a little bit forward into better housing? And the answer was yes. We also identified how the families value the productivity and try to introduce this concept of new house, new life for prevention of disease through the creation of this social facilitation guide that could be employed to help the families transition from their previous environment to the new environment. Another interesting study along these lines was to determine the intentions that the people have to prevent triatomine infestation on their houses. And this was very interesting because a lot of the population of these communities was interested in change. There was a genuine interest of getting rid of the bugs. But what we found is that messaging that hinged on scare tactics did not work at all. And this was later, this was reinforced by other methodologies as well. We have Ben Bates here in the meeting with us, and he's been leading some of these studies using the health belief model, a really powerful tool. Another interesting aspect is that the youth at the community are usually not taken into account when intervention or health problems are discussed. This is the realm of the adults, of the decision makers. But the youth of the community really have a lot to say. So with Belén Marco Crespo leading this project, we engaged this group of teenagers in participatory research where we taught them research methodologies. So the project was a nested project. The students of these adolescents, they studied and conducted this research project on the effects of the healthy living intervention on the local school. They conducted interviews, they kept journals, they did observations, they did employed a number of different tools and came up with this report of their research findings. And at the same time, then the other level was Belén that was studying the process of the engagement of the youth. And so this was extremely important and show us that the youth can be should be a part of the solution and a part of the discussions in the community, and they can be the most important agents of change. Healthcare and access to diagnosis and treatment for Chagas disease is something that everybody knows is lacking. But how do you quantify this lack of access? Because just saying it seems like a good Facebook post. So in this work that was led by Jessica and Julia, we studied the antenatal health practices and accessibility in Southern Ecuador. What do the mothers do and how do they make their decisions in terms of where to give birth? Do they stay in the community? Do they go to the hospital? And why do they do this or the other thing? A very complex subject. And also with the help of Stephen Rue, we conducted a path analysis of what does it take to seek healthcare for these people. Because it's not so easy as calling and making an appointment. You basically need to employ 2 days to go see a doctor. And that is 2 days of income loss, travel, expenses, a place to stay in the city, and so on and so forth. So trying to quantify it and look at perhaps what are the points that can be employed to improve the access of healthcare of these communities. Again, using the Health Belief model, we looked at what people thought about Chagas disease and how could those that do not have a new house improve their chances of not having bugs in the houses. And so developing these messaging and communication tools that are based on the people's own experiences of knowledges. Again, led by Claudia Nieto, this ethnographic grounded study look at the conditions that can lead to the expansion of the housing project to a larger coverage. And the take-home message is that the amount of hurdles is at some points it looks unsurmountable. Just so many barriers, but at the same time there is a lot of opportunities, and so this work laid the ground for this expansion of the project to a regional level that I hope that one day we achieve. But it comes down at the end to the socioeconomics. While people live in poverty, there is and that level of poverty and abandonment, it is impossible to do much. You are trapped, and this population is trapped in this sinkhole where they get poorer and poorer as time goes on. So lifting that has now become part of the or the main part of the project that we're working on. So what can these people do? I mean, they have the land, right? They have they have knowledge, and they have ancestral knowledge that is really important. So how can that be lifted up? So we study the possibility of use medicinal plants and how people were using these for local remedies or cures or teas or things like that. And then we study how these could be implemented in family gardens to improve the family economy and also increasing the production, not only to include the medicinal plants, but also to include food staples. And that could be sold in the market. So this is an ongoing work that is going really well. Also, in terms of income generation, another asset that the community has is sugarcane. And sugarcane is now produced by these in this artisan way in large 1 kilogram cubes. And each kilogram of raw sugar is sold in the market at 50 cents, 1 kilogram of delicious sugar. So now we're working with these farmers to look into possible diversification of the product so that they can produce powdered brown sugar or brown sugar mixed with nuts and other types of derivatives of these that can be sold to the market with value added as a way to create income generation opportunities within the community. And this is there's a lot of hope on that. Also, we worked with women handcrafters. And this was a project that was extremely important because it showed the need to change also the gender dynamics on the population. And this is tough. You know, there was a lot of resistance of the male members of the families to allow the women to become income generation agents, but they were able to break through that, and they have a thriving little business there. And here is a community center that was built as a demonstrative project for the construction of the homes that is now managed by the women handcrafters and is used for social events, for government meetings, for community meetings, for water leadership committee meetings, and so on and so forth. But it is the women who are in charge of this space. And so they have become leaders on the of the community, and that change of gender dynamics has profound effects. And of course, the houses. To date, we have built 8 anti-Chagas homes, and the last home that we built this year was done during the time of COVID, using all the precautions that were recommended and trying to be very creative in how to do this. The last house was built with contributions from individuals, fully fundraised by our social media campaign. And so there is a lot of lessons learned all the time within this. And I would like to finish by circling back to water, because at the end of the day, what the community has as the asset is their knowledge on their hands and the land that they have. So we are working now in the design of a irrigation project that will bring water to these communities for drip irrigation. There's not a lot of water in the region in the dry season, but we already have the plans on their way, and I'm hoping that we're gonna get funding from Rotary International to do this project. 30 gardens are now, productive gardens are in place. And I hope that by the end of next year, we're gonna have 80 productive gardens and a fully functional irrigation project. So partnership with the different local organizations and international organizations is key to vector-borne disease, and looking at the bugs, looking at the parasites is not enough. One needs to look at this from a perspective that brings us to this forest of ideas. And this is a wonderful illustration made by Majo last night, by the way, and she is exemplified in this illustration, a call and an invitation for new researchers, for young people, and for new perspectives to come and join this project. Because what we have done is develop this learning hub with local and international partners. And I'm looking forward to continue working with the next generation of researchers and community members. 15 years is a long time. A lot of the kids that we were working, now they are, heads of households. And so it is very exciting to see that long-term work. Also, this is an opportunity to give students and researchers ways to explore how academic knowledge performs in real life settings while learning from our partner communities. And we have an opportunity to expand these collaborations. So I hope that I was able to exemplify some of the multidisciplinary thinking. I don't want to give you the impression that at day one, I knew what we wanted. On the contrary, on day one, I had no idea what we wanted. And so I'm delighted to have Kevin here with us. He is a medical anthropologist and public health researcher affiliated with the School of Public Health of the University of Washington in the United States and with the Edinburgh Medical School at the University of Edinburgh. He has worked for many organizations in over 20 countries in the control of human, animal, and vector-borne disease. He is the editor of 2 books, One Health, Science, Politics, and Zoonotic Diseases in Africa, published in 2016, and Locating Zika, Social Change and Governance in the Age of Mosquito Pandemics. It is wonderful to have you here, Kevin, and the floor is yours.
Thanks, Mario. Great, it's wonderful to be with everyone. So when Martin approached me about talking today, I can say a lot about vector-borne diseases and community engagement. I've been working on this issue for over a decade on SISI control, so human African trypanosomiasis. I've worked on multiple different, animal-borne tick diseases, human diseases, etc. So I have a lot to say about vector-borne diseases and social and political issues. But I've been working on, with colleagues in Haiti for quite a while, and I was in the middle of preparing a manuscript. So I thought, let me take this opportunity to quickly try to get all the data together for a presentation. So it's quite timely for me. So I want to pick up on some of Mario's points here around sustainability and how community engagement sort of happens. Oops. Oh no. Is this timed? Oh, 1 second here. There we go. Great. So I want to pick up on Mary's points about community engagement. And essentially, I'm going to talk a little bit about a program that's nestled in a much larger malaria elimination initiative called Malaria Zero, which was a $30 million effort funded by the Gates Foundation to help eliminate malaria from Haiti. And as part of that, the Carter Center and colleagues from the University of Amsterdam were involved in thinking about community engagement within this larger program in the context of Haiti and Hispaniola, which Haiti shares with the Dominican Republic as an island nation. And I want to sort of tease out this idea of how community engagement happens, that it's something that we arrive to a program with a very well defined sense of the model that we want to use, or even how to do it. And I actually just want to make the case for the honest discussion about experimentation, about errors, lessons that you learn in the field, and just also about the messiness of public health programs as they evolve in real time. So I've been working in Haiti since 2015, on and off. I led a small project in the north of Haiti funded by the Gates Foundation. We're working with the Ministry of Health, which in Haiti is called MSPP. We developed this pilot project called Policier contre Moustique, which translates from Haitian Creole as mosquito police. It was an effort to as a proof of concept, really, to train community-based vector control sort of officers, which were really community people, right? Diverse representation, to conduct larval surveillance, to work with the lymphatic filariasis program to distribute mass drug administration, so deworming pills, and also to work with the malaria program. Sort of an interesting side story to this, which I won't get into, is sort of the evolution of that pilot project. It was picked up by a USAID project and scaled up in a very large territory, but then just sort of faded. The approach faded because the donor came in and they had their plans, they had their sort of staff, and there was a lot of power dynamics there between the Ministry of Health and the Haitian colleagues that I had set up the original small pilot project with, and this new donor-funded initiative in the context of Zika. And I discussed some of this in a chapter in a book I edited called Locating Zika. But today, what I want to pick up on is this model that we've developed in one department of Haiti, which is called the Community Health Councils. And I want to pose a question. I want to say that there's two paradigms for how we think about community engagement in the context of vector-borne disease. And I would say there are two paradigms that are passing in the night. So they're simultaneously existing, but they're not often talking to each other. And the first one is, I would say, the way that we want the world to work, which is that we have this nicely defined program design. We go out into the field, we want to implement it, we want to evaluate it, and we want to scale it up, okay? It fits the sort of bureaucratic norms of a lot of development funding and global health funding. But the second paradigm, which is much more my own experience in doing community engagement, is that it's a very messy process. It's often very fragmented. You're trying to bring different partners together to value community engagement, to fund it, which is often not very well funded, or it's considered as an afterthought, something you do towards the end of a project because you have a deliverable that needs to be met. And it's also fundamentally, and it needs to be experimental and adaptive, because you don't know how community members are going to respond to your model or to the public health model that's being proposed. So these are the sort of, and I want to today talk about this second paradigm and present some data on how community engagement has been working in Haiti with these councils. There we go. So there's a long conversation that's been going on for decades, centered around community participation in malaria programs, going back to the 1950s with very heavily centralized vertical programs, evolving in the 60s and 70s to this more primary healthcare model of involving communities, then going through the emphasis on public-private partnerships. And we're sort of in this kind of gray zone where a lot of the concepts from the past exist in the present without sort of a central idea of where we're going from here. One of the major buzzwords today is health system strengthening. So if you're going to do community engagement, you need to find some way to strengthen the healthcare system, to link your community engagement initiative to some form of existing health system infrastructure for sustainability. And that's exactly what this model, the Community Health Councils, attempted to do in some kind of curious ways. And of course, there's a spectrum when we're talking about community engagement, from the sort of outreach-oriented stance where you're providing some community information, you're kind of engaged in outreach or consultation, to the much more shared leadership, shared decision-making forms of participation. Now, when we think about malaria in Haiti, the malaria initiative, the Malaria Zero initiative, was promised to be a kind of a jumpstart, a massive sort of infusion of cash to help eliminate a parasite that had been attempted to be eliminated in the 1950s and 60s with very draconian MDA and IRS campaigns under the Duvalier dictatorship, sort of a second attempt to eliminate malaria here. And the group of actors that were involved in this had a number of compelling arguments for why they thought malaria could be eliminated in Haiti over a 5-year period of time. So the project started in 2015 and ended last year. And some of these had to do with the prevalence of malaria, the fact that you only have falciparum that exists on the island. There's no resistance to chloroquine. The vector, A. albuminus, is considered a poor transmitter of the parasite, and there's also little importation of the parasite across the boundaries. But at the same time, when the program started, there was very little strong data on how much malaria existed and where it existed. There was a sort of a large debate about asymptomatic carriers, a recognition that febrile cases or malaria's contribution to the total burden of febrile illness in Haiti was probably only 5 to 7%. And of course, $30 million isn't close to what you actually needed to eliminate the parasite from the island. And so Malaria Zero came on board, and they designed, or they focused on this range of interventions. So on the one hand, it was going to start with strengthening robust passive surveillance, doing work on community-based case finding with community health workers, and then also conducting a number of targeted mass drug administration and IRS campaigns in these high transmission foci. So alongside this effort, the Carter Center, myself and colleagues from the University of Amsterdam were tasked with designing and coming up with, okay, well, how do we do community engagement within this much larger program? And so looking at both the historical data around how the malaria program had conducted or done community engagement in the past, thinking about some of the successes and challenges of programs sort of over the last 20 years with the Clinton Health Foundation and others, we redesign really this concept of community health councils. And I say redesign because in the 1960s and 70s and sort of fading in the mid 1980s, Haiti had a very strong nationwide infrastructure of community health councils that had come out of sort of the post Duvalier, or during the Duvalier dictatorship, but also had a life of its own in the 1970s and 1980s. So the concept of a community health council essentially is a group of citizens in a subcommune, which is approximately sort of 5 to 20,000 people, selected to be representative of different social groups in an area. So local political leaders, religious leaders, teachers, in Haiti, Hougan, which is the traditional voodoo religious practitioners and medical practitioners, women's groups, and local health workers. And this council was supposed to, in the sort of design, basically form a sort of a goodness, losing my words here. This is funny. A go-between. They were supposed to act between the community and the Malaria Zero consortium. So any interventions that were designed vertically were going to first pass through the council before going out to the community, and that would form, a strong tradition of representation and ownership, and also empowerment for these councils. So I'm going to say and make the argument that the community health council model, as we saw it unfold, formed a sort of natural experiment. And the reason that I'm going to say it's a natural experiment was that there was quite a number of challenges that presented itself to us, that challenged us during the implementation of this model in the late 2017 onwards to today. On the one hand, Haiti has faced a number of political crises during this time. Right now, there are riots on the streets. There are police officers who have sort of gone rogue. There's some gang violence in Port-au-Prince. Some of our collaborators can't move from Port-au-Prince to Grand'Anse, which is where the project is located. And this kept on occurring over the last 3 years. So that presented quite a challenge for a program trying to do community engagement. Second challenge was climatic. Actually, the area that we've been working in was devastated with a huge hurricane in 2016, 2017. And also now with COVID, there's also further restrictions that have presented themselves. The second challenge that we faced was that the Malaria Zero Consortium became very focalized on this idea of vertical interventions and saw the community health councils as sort of a tool, right, to help unlock community acceptance for MDA and IRS. And actually, in many cases, tried to circumvent the authority or the centrality of the community health councils, partially because of the fragmentation of, there was different organizations responsible for MDA versus IRS. There were timeline challenges, bureaucratic challenges. And so it was much easier to say, well, let's just go out to the community and start IRS. We don't have to first hold all of these community meetings with these councils and, have to talk to people and try to get their buy-in and involve them in even being volunteers or distributors. That's too time consuming. Let's just go directly to the community. And so we encountered constant sort of challenges around, for example, finding out that MDA is starting next week and we're not even aware of it as the sort of community engagement partner, which is actually quite common when you look at these large consortium projects. Third sort of challenge here were staff shortages and capacity issues. It's difficult in Haiti to find staff who are really skilled at community engagement and will really spend a lot of time out in the community negotiating with people politically and socially. So basically, these challenges created this atmosphere where the CHC model itself, we formed these groups, but then to a large extent, they were left to themselves to self-organize. The original idea was, okay, we're going to go and do all of these sort of participatory brainstorming sessions every sort of month or two and sort of train them over time. But the reality was simply that the groups were trained, formed, and often left to themselves for months at a time. So that's why I'm calling this a social experiment, because it was not apparent at all that these groups would be maintained at all. The other sort of aspect to consider here is the context of community participation in Haiti. So prior to the 1960s, 70s, and 80s, there was a very strong tradition of mutual self-help in farming communities called combit, which is where farmers would rotate assistance to each other in sort of a mutual self-help network. Since the end of the Duvalier dictatorship and going into the 1990s and 2000s with various political crises, that has fallen apart, including the PHC, primary healthcare model of health councils that existed beforehand. And you have a lot of political disenchantment, social disenchantment as well, with the so-called NGOization of Haiti, the expectation that if people from the outside are going to come and try to do community participatory programs, they need to pay money to individuals, and that there's a lot of a sense of a breakdown of social cohesion. Of course, that doesn't exist in every area, but it's a narrative that is kind of permeates the health planning culture in the country. And of course, there's a lot of poverty in Haiti, including in the area that we've been working. So I'm going to present a little bit of data on this natural experiment, setting up these groups, and then all of these sort of challenges and barriers to sort of systematically training them and facilitating them that presented itself during the sort of 2-3 years that we worked in Grandon's department. So here's a map of Haiti in the bottom left-hand corner, and you can see Grandon's in pink there. That's actually the department with the highest malaria burden in Haiti. So if you think, just to contextualize malaria in the Americas, I think it's something like 90 or 95% of malaria cases are believed to occur on the island of Hispaniola, and I think 50% of those occur in Grandon's department. So this is really the hot spot of malaria in the Americas. And here you have in this map, you can see the blue triangles are the original 23 CHCs that we set up in 2018. And this also corresponds to the area where Malaria Zero was conducting their MDA and IRS activities for the most part. And these other groups with the diamonds, those are other CHCs that we set up, but we don't have monitoring data on them. So we actually have 50 of these community health councils across the department of Grandon's. But I'm going to concentrate on these blue triangles here. So again, going back to this question of sustainability, or there's a huge conversation about how do you support community groups to conduct outreach, right? How much do you pay them? What sort of incentives do you provide? How much training and facilitation do you provide? And there's strengths and weaknesses to this, to each side of these debates around inputs, around training, around how much support, etc. So just to present some monitoring data. So basically each CHC provided through phone calls for the most part, an update on their own activities. So we have some quantitative data to present, and then also just kind of going back to this slide on methods. We also have interviews and focus groups that we conducted at 2 different time points in 2 different years, routine debriefing that we conducted with the groups, and then also this sort of 19 months of monitoring data. So what does the data show us? Well, first of all, kind of optimistically, no group actually ceased functioning over this project period. So the 23 of the original CHCs conducted, almost 400 or 250 group meetings. The expectation was that they would hold a group meeting each month. And if you see on average here, 0.86 meetings per month, almost met that target with a very high attendance rate of 78%. Interestingly, you don't see any consistency in the number of meetings that these groups held. They were very variable. Some months they would have 2 or 3 meetings where they were planning an activity, and then they would drop off for 2 or 3 months and stop sort of functioning, well, not stop functioning, stop working actively in the community, and then they would come up. And that often didn't follow any predictable pattern. And at the same time, all of them didn't hold monthly meetings for at least four months during the reporting period. So I'm kind of making the argument that this high level of fluctuation in the number of meetings is actually indicative of a high level of local ownership. If you're a group, you're going to organize yourself according to your busy schedule, sort of the time of year, what other activities are going on in the community, and the expectation that groups are going to be consistently doing the same number of meetings and the same number of activities every month is just not realistic, right? When you think about groups taking local ownership and adapting things to their own needs. We also see from the qualitative data, we see a number of interesting trends here around membership and planning. So as I mentioned earlier, the formation process was actually one that we were quite deliberate about, of choosing members from diverse social groups at a sub-commune level. And that really did set the process, or set the bar quite high for a sense of representation and democratic decision making. So there was voting processes that the groups kind of created themselves, different ways that they tried to balance power between the secretariat, the treasurer, and different political forces that were also operating in these communities. We also saw that the groups developed their own sort of micro-planning tools. So they developed oaths, mission statements, songs, statements of purpose that were often centered around this concept of solidarity, which, going back to my earlier point about this traditional concept of combit, or social solidarity and mutual self-help in Haiti, just trying to sort of regenerate that sort of lost sense of community cohesion. There were efforts to create WhatsApp groups, which didn't really quite work so well because this area has very poor internet and some other aspects around that. An important point here is, when we originally set this model up, we weren't quite explicit around, okay, are the community health council members, the 10 to 15 people who make up this group, are they going to go out into the community and sort of do education themselves? How is that going to work, right? And essentially all of the groups saw themselves as facilitators, and then they mobilized or recruited their broader social networks to engage in specific activities. And then, of course, we had some challenges around monitoring. We tried to implement an iPhone reporting system that just didn't work. The phone kind of got sort of lost by the coordinator, which kind of gets back to this sort of long conversation that we're continuously having around how many inputs should we provide to these groups. And my Haitian colleagues being very emphatic that no, we shouldn't be providing money to these groups. We shouldn't be providing inputs. That's going to create expectations, and it's going to just derail the whole process. And I would actually push back and say, no, these groups are doing work in their communities. We should provide some support to them. And so we're constantly having this conversation around inputs, which I'll get to in a second. So going to community-based activities, the expectation, or the sort of idea that we had was, okay, each group is going to do, 1 monthly meeting and 4 community-based activities per month, right? With our sort of mindset. And we see over this almost 2-year time period, 19 months, that on average, the groups conducted 1.8 activities per month with some fluctuation. And again, we see this high fluctuation in the number of activities, and also sometimes where the groups are kind of laying dormant. And then in terms of the number of people reached, we also have some data on this, which I'm not going to talk about so much. So what types of activity did these groups, which largely self-organized, conduct? On the one hand, they focused heavily on schools and churches. There's a high trust in religious leaders, and the groups also felt that by educating school children, that they would carry the messages home, and that would be a great way to sort of spread messages at a community level. There was also a major focus on garbage cleanup and environmental sanitation campaigns. So a lot of efforts on, picking up plastic objects, piercing tires, reducing pools of water, and then also addressing much larger stagnant water sources, even canals, and thinking about water systems, as you can see here in this picture. And of course, some of those are not effective at all for malaria. So from a malaria standpoint, focusing heavily on garbage cleanup is not going to be particularly useful. However, it connects to two sort of local motivations. One is this idea that malaria is actually spread by dirty water, or it's spread by mosquitoes that are also breeding in plastic objects. So it connects to local concepts of malaria. And secondly, these groups would get a lot of political brownie points by having these large public displays of a campaign and mobilizing their, even in many cases, political sort of networks to be involved in cleanup. A lot of education at festivals, and also advice for how to, where to test and how to deal with suspected cases. And also getting back to the original sort of Malaria Zero, from their standpoint, their emphasis on getting the CHCs involved in the MDA and IRS campaigns. So we see a couple of interesting things here from the community
Kevin?
standpoint. Yeah.
I'm sorry to interrupt. We have about 5 more minutes until the next presenter is scheduled.
Great, wonderful. So a large language on solidarity, people feeling they're valued, they're useful, and they're being seen as a sort of motivation to maintain participation in these groups. There's a consistent sense that there needs to be some small incentives that are provided to the groups. There's a couple of ways these are discussed, and actually, interestingly, one is even a symbolic exchange. Having resources provided by the Ministry of Health or the external partner because they care about us. So it's not necessarily that it's a large amount of money, but there's a symbolism there of partnership that takes place in the transferring of resources. And of course, a lot of these groups actually use their own cash to buy rum or water during these mass cleanup campaigns. And so it was also seen as a form of reimbursement. And then of course, the program also provided some supportive tools like wheelbarrows and cleanup equipment during different times of the period. And the groups were constantly discussing sort of the limitations of volunteerism or the appropriateness of volunteerism, because from their standpoint, they know that the people who are coming from the Ministry of Health or from the Carter Center or elsewhere are being paid to be involved in this campaign. And so there was a constant negotiation around inputs like that. And of course, they also had to negotiate this because from a community standpoint, the assumption was if you're part of the group, you're being paid to be part of the group. And so there were a lot of rumors around how much these members were being paid, their sort of relationship to larger political elections that had to be actually communicated and sort of debunked constantly over the time period. So I think just sort of winding up here, thinking about time, there's a lot of kind of contextual details that I'm just going to kind of gloss over a little bit here. So thinking about, okay, well, what kind of lessons can we draw from this experience to talk about community engagement in vector-borne disease control? So essentially, despite the messiness of the CHC program to date, the challenges that we faced, this sort of self-organization that many of the groups were required to take, they've become self-sustaining groups that do meet regularly to plan and organize monthly community-based activities. And now with the end of this large consortium of Malaria Zero, the question is, well, what do we do now? So we have these 23 groups in one area, 50 groups across the department that are actively conducting these community-based activities. What next? Curiously, if the epidemiology of malaria in this area, the parasite's actually gone up over this period. So there's some major questions around why that's taken place with, despite all of the best efforts of Malaria Zero, there's actually more malaria today than there was in 2016. And then there's questions around how to link these groups with epidemiological data so that the activities that they're doing are actually effective for malaria prevention and control, rather than just leaving them to conduct their own activities with very little epidemiological guidance. So just to conclude, the way that sometimes these programs work is you end up with your model after you've muddled through for a period of time. So after sort of going through this process for 2 or 3 years, we've come out the other end with a very clear idea of well, what does it mean to create a CHC, a community health council? What are the steps involved, and how should partners implement these types of groups? So we've created a manual and also an M&E handbook with very clear guidance on monitoring and evaluation and learning, which we've translated into French, and hopefully we're planning to use that in other areas of Haiti, with the Ministry of Health really leading that effort into the future. So thank you very much.
It is my pleasure to introduce our next speaker, David Malone, who is a senior program officer on vector control and malaria in the Bill and Melinda Gates Foundation. He has experience working in mosquito and insect projects. And examples of these are from 1990 to 2008, the vector control applications, vector surveillance and resistance monitor, product development in Southeast Asia, Central America, the Caribbean, and the United States. And from 2009 to present, in malaria vector control product development and resistance monitoring tools, IVCC in Liverpool, Sumitomo Chemicals as partners. So without further ado, David, the floor is yours.
Okay, hi there. Thanks for inviting me to present. Obviously, it was quite short notice, but I do appreciate you contacting me and bringing me along to join the group. And so I don't have too many slides, and I'm going to be fairly brief, hopefully. But so I'm going to just go on to my first slide and try and share my screen. So I'm just going to say a few words about. So yeah, my intention is to really try to give you a bit of an overview of the Bill and Melinda Gates Foundation's malaria eradication strategy. And obviously, while I'm presenting, I can't see anybody, so I'll just keep going and hope that you're all okay with that. Just so that you're aware, I mean, I joined the foundation 18 months ago, and obviously the headquarters are in Seattle. I am currently still based in the UK. I work out of the London office, but the intention is at some point I will relocate to Seattle, but due to lockdown and COVID, we've all been working from home. So I'm still located not too far from Liverpool, and obviously we can't get haircuts, hence the hair problem that I've got at the moment. So
I cannot see your screen, David.
You can't see my screen. Okay. Why is that?
You can see you quite clearly, though.
Oh, right. Okay. Perhaps you can see that.
Yes, we can see it now.
Right. Sorry about that. Okay. I thought that you could see that and not me, but there we go. So obviously I joined the foundation 18 months ago, and the fact that I'm able to present even a few slides on our malaria strategy shows that I've been able to absorb everything that's going on, because it is quite a complex organization, and our malaria strategy is pretty broad, and it extends way beyond vector control, which is my area of expertise. And I'll just say that also, within the foundation, although I am part of the malaria team, our NTD group are obviously also pretty active, and they don't have any vector control people of their own. So I provide support in the vector control space to our NTD group as well. So they have a focus on onco and lymphatic filariasis, and also some leishmaniasis projects, predominantly in India. So I just thought I'd mention that I do sort of extend into that also. So one of the things I think that's fairly clear about the Gates Foundation is that from our malaria team viewpoint, our aim is for the eradication of malaria, and how that's defined is obviously depends on your viewpoint, but it is all about malaria eradication from a strategy perspective. And this has been broken down into various different components that you can see on this slide in front of you. So we have a team who work on malaria surveillance, data, and epidemiology. And actually, there is also a component of that, which is vector surveillance. And again, we work with the vector control team, works with the surveillance team, as obviously there's some overlapping expertise needed there. We do a certain amount of in-country engagement. I mean, obviously, we're not like PMI or the Global Fund, who are major implementers of in-country implementation, but we do support various activities, predominantly through grants to organizations such as PATH and CHI, who we support. And actually, we've just recently started recruiting some Africa-based staff, again, to sort of really support this focus on in-country partnership and engagement. So I work in the vector control part of the Foundation's malaria team, and I'm going to talk a little bit more about that in a minute, but we basically have two broad areas of work. We have insecticidal-based vector control and modified mosquitoes, so that's all of our GM-based investments. And I work basically on the insecticidal side of things, and we have Laura Norris, who works with us. She looks after our GM portfolio. We also have still some major investments on anti-malarial development, as you can see on this slide here, and we do still support some activities on vaccine development for Plasmodium falciparum. And then there's a small component of our team who work on advocacy and communications. So if you just look at the top line, this gives you an idea of the split of our budget. So, you know, it's a fairly even split. And one of the things that I'm very pleased about, obviously, is that vector control is considered pretty much as an equal partner to the other parts of our malaria strategy. And that is really based on the fact that all of our modeling work indicates that we need vector control at every stage of malaria elimination, whether you're at the beginning or the end. Vector control seems to be an essential component of that. If you're interested, I mean, our current budget in the team is something like $290 million. Obviously, that doesn't always remain the same, but that gives you an estimate of where we are on an annual funding perspective. So one of the things that I think is really important about the malaria strategy, which was refreshed in 2019, is that we are, I mean, obviously I joined after this malaria refresh, so strategy refresh, so I joined into it, but it's very much focused on the eradication backbone of Africa. So there's a big focus on high burden countries and aiming to have high impact. And that probably fits quite well with a lot of our work, particularly on insecticide development, because the malaria transmission in many of these parts of Africa is influenced very much by insecticide resistance. So we have a big program on insecticide development to overcome resistance, which is a major feature of these regions. Saying that, we don't just work on projects in Africa. We do still have activities going on in the Greater Mekong, and we also have a very early stage project with Oxitec looking at genetically modified Anopheles albuminus, which is obviously more of a Latin American Haitian type vector. So we're not 100% focused Africa, but it's certainly where our strategy is aiming towards at the moment. And then I was just going to focus really on where we are with vector control, because that's my area. And as I say, we've really got this divided into two. We've got insecticidal-based vector control and the use of genetically modified mosquitoes. Now, our biggest grant in the area of vector control is with IVCC, who are based in Liverpool, and that's where I used to work for nearly 10 years. And IVCC is funded by us and others, predominantly to work with industry to identify new insecticides as alternatives to pyrethroids and as replacements to them in areas where resistance is a problem, and also to work on novel vector control tools. So in that respect, we have a major focus on attractive targeted sugar baits, ATSBs, and these are basically a type of lure and kill approach to vector control, which makes use of the sugar feeding aspect of mosquito biology, which is something that has largely been overlooked for a very long time. We've been working with a, well, it's an interesting project actually. There's a grant directly from us to a company in Israel who are developing a product in this area. And there is also an activity that RVCC is leading on generating the evidence base to support a WHO recommendation for this type of product. And this basically uses, the approach is basically a device which attracts mosquitoes to it. And when they land on it, they feed on a sugary solution which contains an insecticide, which is then obviously ingested by the mosquito and toxic to it. We do also have some other investments around the insecticidal area. We have got, actually this is how I got introduced to this group. We're doing some work with Alvaro in Liverpool on the tyrosine pathway inhibitors that I know that he's worked on in relation to nitisinone, and we're funding some additional work to look at this whole class of chemistry more broadly and look at its activity predominantly with a focus on ATSBs. Can we use these kind of compounds in sugar baits or other methods of delivery? We also have quite a big project with some Chinese collaborators to look at libraries of traditional Chinese medicine to see whether we can identify insecticidal compounds from them. I mean, there's quite a lot of history of people looking for anti-malarial products from them, obviously, but the insecticidal piece has been neglected. So we have a sort of joint collaboration with the Chinese, their equivalent of the National Institutes of Health in China, and the foundation to work on that. And then we also have what I think is a fairly speculative but very interesting project with a Swiss company who they develop things like flavorings and ingredients that go into many products that we use in day-to-day use, things like soap powders or perfumes or soaps. And we're looking to identify repellent type compounds that might fit as ingredients in these sort of day-to-day products. And obviously the long-term objective there is to have consumer products that are bought through regular supply chains and provide some kind of protection from vector-borne disease as well. And then from a viewpoint of the GM side of things, which is not my expertise, we do have several different approaches running in parallel. So we work on some self-limited gene genetically modified projects, largely with Oxitec. And I think you can see on this slide, they're currently working on both Anopheles albuminus and Anopheles stevensii. And then we obviously have major investments with Target Malaria, who are pursuing some of the gene drive approaches, which is predominantly focused on Africa. Okay, so that is my final slide, and this, as I promised you, is only a very brief sort of presentation to give you just a high-level view of things that are going on in the foundation and where our major focuses are currently. So I'll just open to the floor to any sort of questions or comments that you may have.
It's my pleasure to introduce Cohen Peters. There you go. Professor Cohen Peter, greetings, and heads the Socio-Ecological Health Research Unit at the Institute of Tropical Medicine in Antwerp. He is a senior lecturer at Nagasaki University and is affiliated to the Amsterdam Institute of Social Science Research. He holds a PhD in social and cultural anthropology and has conducted extensive research in sociocultural factors related to infectious disease transmission dynamics, community perceptions on health and illness, and their impact on the effectiveness of disease prevention, control, and elimination strategies. His professional experience is characterized by high international mobility and extensive field research on low-income countries in West Africa, Latin America, and Southeast Asia. Cohen, it's so wonderful to have you here. The floor is yours.
Thank you, Mario, for the invitation, and Martin. Let me share my screen. I hope you will see my presentation without me being interrupted by a whole bundle of kids, because I'm in the same situation lockdown-wise as everybody else. Do you see my screen properly?
Yes.
Okay, good. So my talk will be a little bit different, first of all, because I don't have any experience of community participation in Venezuela or other countries of Latin America. So I'm really going to be talking about my experience in Southeast Asia, and mostly on vector-borne diseases and malaria. So I will give some concrete examples of my points, and also try to look at what my findings are, or my conclusions are, after all these years of setting things up there, more at the conceptual level. So yeah, I called it the impossibilities of community participation, because there's a lot of tension I find there. So this is just us. Now, a first thing to comment on is, and I wanted to start with this because in most of the projects where we have been asked, for example, as a team to engage in community participation or set up any forms of community participation, actually the real question was about the effectiveness of an intervention instead of really on empowering communities. And I think that's the first distinction that comes up a lot. And a lot of times the community participation or the projects do not work because we are not clear about what we want in this sense. So I wanted to go into that a little bit. So first of all, as you know, community participation is about communities being the protagonists of processes of change. I will not go into these definitions, but just I to point it out a little bit. Deliberation, participation, public affairs. Empowerment, for example, communities become empowered is very often stated as one of the aims, as for example in the studies that Mario presented initially, and also the kind of evaluation and of local forms of knowledge and action for social change. Now, what I see very often, like I said, is that when people actually talk about these community interventions, what they want is they want a vector-borne disease or their vector control to work effectively. They do not necessarily want to empower the community, but they want to involve the community to be able to get better effectiveness of interventions. Now, when we look at these interventions and then this effectiveness itself, engaging communities is a good aspect for that. But we have also noticed through the years, of course, there is no direct relationship between engaging communities and having communities be in that position and having effective interventions. So in addition to this community engagement, what very often comes up is acceptability and the appropriateness of the vector control tools themselves that people have to adhere to. And this adherence is then very often related to interventions of behavioral change. So first, if we look at acceptability in this context, we were part of testing topical repellents and different types of bed nets, for example, in Vietnam, Cambodia, the border areas. And I think one thing we've learned, despite all the acceptability studies we have done and still are asked to do, and it is not about acceptability at all. So it is good to have acceptability of a product. People should kind of accept what it is, but it does not translate in use. And so it does not necessarily translate in an effective intervention. And we did this study in Ratnakiri in Cambodia where people were supposed to use, with Bill and Melinda Gates funded, for example, were supposed to use these topical repellents for early and evening biting and outdoor exposures. And you had like 100% of acceptability. But when we really looked and measured the use, we could only get to around 8% of use. So there is a huge gap between people finding something acceptable and actually using it. Another study we did before that was on the alternative to mosquito LLINs, which are the LLIH, or the long-lasting insecticidal hammocks. And we did this in several areas of Vietnam. And again, there everybody was very happy with the hammock. It was completely acceptable. It seemed like a perfect solution. But after some months, we saw that actually 50% of all the hammocks were already broken because of the fact that the flap that's hanging out, that you can see in the picture, for example, would be broken by the bamboo housing and children and chickens, etc. And that people actually, like the farmer in the middle, found it a very good material to bring their chickens to the market. So again, very high acceptability, but it didn't translate in an effective intervention. Now, in addition to this acceptability that we always want, we then say, yeah, we should introduce some behavioral change, right? People have to accept it, but they also have to use it. So we want to get information education campaigns or all variants of behavioral change models. Now, I wanted to just introduce one concept out of the social sciences in this talk. I promise it will only be one concept. I won't introduce two, but that is the marking of specific things. And I gave you this picture of Dutch artist Escher, and it basically refers to the fact that you can not focus on both things at the same time. So the question is then, it relates to the theory about what do you mark, like what do you put emphasis on, what do you put to the foreground, and what does that then automatically put in the background. And an example of this that the US is always very nice to use as an example for these kind of things. So one example that makes it very clear is the marking of race. Yeah, Obama is a black man with a white mother, or is it a white man with a black father? Yeah, you could say he is 50-50, so why do we call him a black president and not the next white president? And that has to do with the fact that it feels you have to mark the fact that he is black, because white would be the standard thing that nobody feels needs to be mentioned. Yeah. Nobody says that we are part of a white community, for example. You say you are part of a black community because the white community is kind of the default. Similarly, you would say somebody is openly gay, but you won't say I'm openly straight, for example, because it seems like that's not necessary. And you have a working mom, for example, but none of us here are working dads. Yeah, we're just dads. We're not working dads. This is just, I cannot not have the opportunity to do something with Trump. Like Ivanka Trump said, people ask me, what did your father say about women? And I said, but have you looked at the things he said about men? Yeah, valid point coming from Ivanka Trump. But so the thing is, we feel the need to put emphasis on specific things, to mark these things, but we do not necessarily always then live with the implications of what we are unmarking or what we are not looking at. And this creates in science, for example, science, a scientific field, let's say the vector-borne control field, is an attentional community. It's a community where you have specific traditions, habits, and you look at your work in a specific paradigm that will bring certain aspects to the foreground and other things you will not articulate. Now, if we then look to behavioral change and the fact that we want to change people's personal habits and attitudes to prevent a disease, in my experience, this very often puts us in a very uncomfortable starting position, both for research as for interventions. And since it's so common, I do want to stop at and put some emphasis on this for 1 second. It's not that behavioral change is necessarily not okay, but we have to look at, if we focus on this, what are we missing, right? And if we think about this for social change as a paradigm for social change, we kind of assume that this change that people are required to make depends on their attitude, as always. Think about the numerous CAP surveys everybody does. On the attitudes, then their behavior, and that everybody chooses to adopt a different behavior after a while. Now, what does this really mark and what does this really hide? And first of all, this focus on behavioral change also puts an emphasis on the fact that the behavior people have is sometimes somehow not okay, right? It requires changing. It can be changed, And this can be done by specific strategies, and also that this is the best way actually of acquiring this social change. And what we kind of neglect when we do this in these projects, and this includes the projects where we have, for example, community participation, is we do not look so much at the systemic factors that make this either possible or impossible. And in that sense, I was very happy with Mario's presentation as well, because it included a lot of examples of the systemic factors. But I just wanted to give an example on Vietnam, for example. This is one of the last remaining hotspots in the mountains there, where you have a high malaria prevalence and incidence, and where you have all these interventions that target these villages. It can be community involvement, it can be other forms of interventions like the hammocks, extended bed nets, even the government, like you see in the picture here, they build complete new housing for these people to prevent vector-borne disease. But these are two small shots of drone footage. So here you see this village in the district of Bac Ai. So the minority that lives there, they receive this from the government. They receive these concrete houses as a form of making them less poor and as a form of preventing disease. But what you can see here is that there's nobody there, right? So especially during the malaria transmission season, actually the streets are completely abandoned because the people actually live here. So in the little clip that's moving now, you see that everybody moves to what they call their traditional villages in the middle of the rainforest. Now, people will not tell you this because the government demands that they live in the other village, right? And so everybody is looking at the other village. They will all have their bed nets up in the other village, their hammocks up in the other village. They have perfect access to care because the health center is there. But people are actually in the middle of the rainforest, as you can see in where the clip is moving now. This has to do with a lot of sociocultural factors, and being close to their fields for subsistence is one of the main ones. Now, this is very structural, so you can tell these people, as the Vietnamese government is puts a lot of emphasis on, you need to move to this other village. But if you're just going to require this behavioral change without looking in the social background or why this is not happening, you cannot create a lot of impact, of course. Now, that doesn't mean invalidate the behavioral change, but it means that we have to start also from the research at what are these systemic underlying factors to make anything work. Now, this then relates to how do we see what is the nature of social change. And a second thing I find where we can improve very often a lot the effectiveness of interventions, and that can be interventions related to research, like in specific studies or trials, or just disease prevention in general. That is, if we look at how a control program sees the world. So we always have the tendency of looking, oh, this is how people, behave, and that's what they do, and then that's what they should do. But we very often forget that actually a control program also has its own logics, and very often there's reasons why they fail to address these problems. And the pictures here and the new clip are from gem mining in Cambodia. So these are temporal settings. So these people go there, and usually it's young, like pre-adolescents or adolescents, that crawl into these holes in the ground to get the precious stones out. So they're very vulnerable to malaria, all kinds of diseases. But the problem is nobody sees them. Like no control program sees them because they're obviously not registered in the area where they are. And even if you try to register them, very often they will move to other parts. So you have the logic of these control programs that does not see where the vulnerability is in terms of vector control sometimes. So I think this seeing like a control program is a very nice way of improving vector-borne control as well. Now, a second element that we always see when we look at community participation is that, first of all, we want an effective intervention. That's the first main thing. Secondly, we kind of want to overcome the fact that we're always working under universalist premises. We want a magic bullet that works everywhere. We want one intervention that we can copy, paste, scale up, universalize, however you want to call it, everywhere. And we think that community participation is then going to be kind of the magic bullet to adapt this universalist intervention to a local context. But the problem here, again, of course, is that there are no standardized communities, right? There is no way of saying community participation has to be like this because the communities work like this. There are no communities that work in a specific way. For example, in Vietnam, in the example before, it's ethnic minorities that have had year-long conflict with majority society. Or you can have, like the picture in the right corner, it's a picture from an ex-FARC settlement in Colombia, for example. All these contexts are so different, and this increases with increasing heterogeneity also in epidemiological terms. And since we go closer and closer and have lower and lower prevalence for certain diseases, this heterogeneity will become more important, and the fact that there is no standardized community will become more of a problem as well. So currently, like in malaria research, we have this worldwide standardized information and audit infrastructure, right? And that has a lot of advantages. We can measure and compare progress towards elimination. We can do cross-national research. We can cater to the policymakers, to the funders. We can have evaluation mechanisms for disease control. It works as an accountability mechanism as well. You can show what you did with the money, etc. But it is not a good thing to localize interventions. We are supposed to, like the OLISAT nets, for example, are supposed to work in Burkina, in Vietnam, in Peru, in the Amazon, in the same way, and they do not. And we will see this in an example. So how do we contextualize this intervention? And is community participation the answer to that? And I think it is not. It can contribute to it, but again, it can contribute to effectiveness. It can contribute to contextualizing standardized intervention, but we cannot expect it to be the magic bullet to overcome this. We need more for that. And one of these aspects where we see it goes wrong a lot is that actually interventions or tools are not appropriate in a specific context. And I very briefly give this example of the Peruvian Amazon. And I'm sure the people of you that have worked in the Amazon and other regions will find this just the same. So on the right, you see, of course, the Mercedes of bed nets, or the OLISAT net. And on the left, there's the Tocuyo nets that people actually use in the Peruvian Amazon. Now you see that the characteristics are quite different. So the OLISAT net is completely transparent, while the Tocuyo net is not transparent at all, and it gives people some privacy. And if you compare this then with housing structures, you also see that some houses are open, they don't have rooms and doors, while other houses, mostly of people that can afford to build the rooms, they are closed. So what it means in terms of the bed nets used is that the richer families that have rooms do not need to get privacy from the bed nets. But the poorer families that do not have external walls, they do need the bed net to provide that privacy. And here, of course, you see an example of this. And people would say, which I think we can all relate to, yeah, but my mother-in-law, she sleeps in the bed net next to me, and she wants us to have kids soon. And then I'm supposed to sleep in a bed net that is transparent. Of course, that is not going to work, yeah. People want privacy, and the OLISAT nets that we want them, for example, to adopt cannot provide this. So we cannot demand from people in a setting like this, for example, that they adopt a tool that is not appropriate in that context. And community participation can be a way of negotiating this, but it is not something that will overcome the fact that we forcibly want to localize standardized interventions, and that is something that will not always work. Another problem we see in Southeast Asia a lot, and it's a very common pitfall, and I think the idea here was a little bit to see, okay, what can we do in specific contexts in Venezuela, for example, or other parts. So is that to avoid reducing complex context to simple targets. And I know this is not so easy, and it's also not a criticism to these terms per se, but it shows my point will be later, that we need specific and complex methodologies to be able to make community participation and these interventions work. For example, outdoor transmission. Yeah, all Southeast Asia now, it's about outdoor transmission. But we've published a couple papers on this, measuring mosquitoes indoors and outdoors. And as you see in these contexts here, for example, so is this outdoors or indoors for a mosquito? It's not so clear to say, yeah? So it's good to look at outdoor transmission, but let's not ignore that with increasing heterogeneity, the people that get malaria are these ones and not the ones that live in a house with clear indoor-outdoor distinctions, for example. Another thing is the early biting. We've also published several papers on this, but somehow I think nobody reads them, so we have to reconsider our our publication strategy, because every vector study that I read in the area measures early biting before 10 o'clock in the evening. If mosquitoes bite before 10 o'clock in the evening, then it's early biting. But we've shown in all these contexts, people at the fields, for example, where they live, when they work during malaria transmission season, more than half of them are already asleep before 7 o'clock, not 10 o'clock, 7 o'clock. So you have a gap of more than 3 hours that people are already asleep because there's no electricity, there's no lights, there's nothing to do. That you can talk about early biting, but it is not early biting as in after 10 o'clock people are protected. And another thing we see is, given these high mobility patterns, is that bed nets are not very often transported, which then again kind of invalidates the point that the problem is early biting, because these mosquitoes can actually bite all night long. It's again not to invalidate the fact that this early biting is increasingly a problem, because that is true. But the question is, if we set this as a target, very often it then starts distorting the field and the interventions that we want to make. And a good example of this are the MMPs and at the Vietnamese and Cambodian border and Myanmar and a lot of these places. So MMPs are mobile and migrant populations. So while there is a lot of problem with mobile and migrant populations, at this moment, most interventions are actively looking for them and trying to fight these mobile populations, which often leads to absurd situations, for example, of areas where you have migrant populations coming in outside of the malaria season, and they are targeted, while ethnic minorities, for example, that live in the forest half of the year, they're not targeted because they're not migrant populations, yeah, while they are mobile as well. So these concepts, they lead us to look at a reality that very often has already changed, or very often is very difficult to define. And this is less the case in stable populations and stable conditions. But if I think about Venezuela, and you have, for example, miners and loggers and all these kind of problems, new settlements, they will all be facing the problem that they're very hard to define and moving target. And I think this is something we really need to take into account. And this is a little bit these changing realities, right? In Cambodia and Vietnam, it's mostly related to the trade of forest products. And this changes. You have here, for example, in Odermenche with the Thai border was a very big hotspot, and it still is to a certain extent for malaria transmission, but the rosewood people are logging in these forests is coming to an end, so people will move again. Rubber plantations in Ratanakiri was another hotspot, but again, the problem or the change there is that this becomes more and more industrialized, so less and less improvised, like in these pictures. So we have to be careful that, you know, the delay in time that it takes us to set up an intervention, that we're actually still looking at where we're supposed to look. Now, many problems, a lot of complexity, but I think this is not to, not encourage us. I think the only thing is we have to really take into account that for the effectiveness of an intervention, we need to see at the uptake of it, how is it localized, and include community participation in this whole puzzle. And the only way, in my experience, that this can be done is, of course, you need the long-term engagement, you need to build trust, but also, and I think that is something that is not always done somehow, you need to have research into how to set up this community participation. And like Kevin said as well, it's a moving target and it goes wrong, etc. So you need to look into how to set it up properly. And in addition to this, you also need, as this community participation is not the magic bullet for that, into how do you localize, or how will you contribute to this effectiveness of the strategies that you want to implement. Now, there's a lot of methodological work on implementation research that then includes community participation. And I think the main characteristics of this is that we need an implementation, and you need to research this implementation. If you do not have a standardized context, it's very hard to expect that your intervention will magically work without research, without localizing it somehow. And this implies that you have to look at what we call emergent theory designs, basically flexible designs, and not the standard, for example, clinical trial designs where you set something up and measure it at the end. You need to continuously improve what you're looking at. And this, and I know Mario and other people have talked about this many times during this conference as well, that all requires mixed methodologies and transdisciplinary approaches. And so from my personal experience, when we see standard clinical trial approaches, for example, in these very specific contexts, it usually does not produce very effective interventions. And I think these three characteristics should be met to set up really good interventions and allow also community participation to be a good part of this process. We have some publications on what we call the Community Lab of Ideas for Health, or CLAI. We did this with the MRC in the Gambia, quite a bit of it. This is not to sell this approach, but for people that are interested at our experience in how to set this process up, you can always contact me, or we can have another Zoom call or via email or something. And the only thing here I really want to start with is the relevance of having informal data collection like ethnography, because in many of these interventions, when you measure them, data are so biased because people get a free of charge intervention, or people have to face somebody that's higher up in the social hierarchy than them. So it's really very illusory to think you can grasp their social context and have real good answers to people's problems and how to adapt to a social context without these type of methodologies.
It is my pleasure to introduce one of my personal heroes, Dr. Mariana Santamartino. She has a PhD in education sciences. She's a biologist and a specialist in social sciences and health in the epistemologies of the South. She works as a researcher for the National Board of Scientific and Technical Research, CONICET, and the Grupo de Didáctica de las Ciencias in La Plata, Argentina. She is the founder and coordinator of the group De qué hablamos cuando hablamos de Chagas, or what do we speak about when we speak about Chagas. The guiding thread of her career is the search to understand Chagas disease from an integral perspective, and at the same time highlight the role of education and communication as the key tools to address this complex issue. Mariana, thank you for being with us. You have the floor.
Well, thank you very much, Mario. Your words are so big for me. I want to say one thing. Today is the National Day of Memory for Truth and Justice in Argentina. We commemorate the 45th anniversary of the military coup, and it's a very, very special day for us. I wanted to say that. And I wanted to say thank you very much to you, Mario, and to Martin, and to everyone. And I will start like a colleague from Catalonia start his English intervention. So I will start sharing my screen. It's okay?
Yes, we can see your screen.
today I prepared some, I think my presentation is short. I wanted to share some reflections, some background from the work we do here with Chagas disease, and I think it's useful maybe to think another vector-borne diseases. I hope so. As we know, well, we have Chagas, a problem that we know from more than 110 years ago, and even if we don't have the best drugs and the best diagnosis and the best ways of control the insect, we have them, but we know that only 10% of people who have Chagas know it, and only 1% have access to treatment. So if today we have not the best, or even if we have the best technological things for treat and prevent this health problem, we have another problems to solve there, because these numbers are saying things to us that we should hear more carefully. So we think that one of the problems is that we've been thinking Chagas from a very fragmented way. So we propose to think about Chagas in the first moment as a puzzle of 4 pieces. And we know a lot, and we talk a lot about biomedical and epidemiological pieces. That's where we consider all the things that has to do with the insect, the parasite, the symptoms, where people is, the numbers, the statistics, but we are underestimating the other pieces of this complex puzzle. And that's why, for example, the words of el querido Roberto Briceño León from Venezuela are still vigentes, I don't know, are useful for today, because we know a lot of things about this biomedical piece, this epidemiological piece, but we still have to know a lot of things about people who suffer from Chagas or who live under the risk of having Chagas. And there is one, not all, but one of the keys that will allow us to change these first numbers I shared in a previous slide. So that's where, when we think about this, is where, for example, the socio-cultural piece became so important for understanding and facing the problem. In this socio-cultural piece, we have all the elements that has to do with people and with the people lives, not only in rural spaces but also in urban spaces. Nowadays, we know that 2/3, 2/3 of people who has Chagas live in cities, and not only in cities from Latin America, also in cities of Japan, Europe, Africa, United States, Oceania, all the world. And this situation gives us an extra challenge. We not only need to understand the particularities of all the rural settings where Chagas exist, only now we have these urban and outside Latin American realities that we must understand to face the problem in a situated, contextualized way. Yes. In this, also in this socio-cultural piece, we have all the things that has to do with our prejudice and our social representations and our ways of thinking people affected by this problem. If we see, I work a lot with communication and education, and we still see these images of only one kind of stereotype. It's an English word. Yes, of this stereotype is so so fixed in our discourses and and all the education and communication material about resources about Chagas. It's something we should think again and again from a critical point of view to have useful and respectful interventions. And for example, and based on this stereotypo and in this discrimination and this prejudice I was talking about, we have, for example, in Argentina, nowadays, Chagas disease is still an excuse for discrimination, for labor discrimination, due to an old law that is not now it's not in place, but this situation still happens. People that has Chagas sometimes doesn't find a work here. And we can have, for example, we can know a lot. We can we can help attend someone who has Chagas and give him the medicine and give him all the biomedical attention. But if this person doesn't find a job, there is another problem that we should face, not only the biomedical thing. That's what I am trying to say in this complicated English. And so the fourth dimension that we propose, this is a proposal to think Chagas and other health issues. It's not a model, it's a way of thinking. It's an invitation to think things like this. So the fourth dimension we propose, it's this political one, when of course we think and we describe, we have there in this dimension all these people who has our lives in their hands, in their laws, in their decisions, the government, the politicians. Of course they are in this dimension, but we must consider in the political dimension that also we have the economical issues. All the economical decisions that, for example, a founding agency has to give funds to some project, yes, or some project no, has to do with political issues also. And in this dimension, we invite all of us to think about our role. It's easy to say, oh, politicians don't do what they have to do, or economical thing. It's I am a researcher. I has nothing to do with economical decisions, but you are, each of us are people that has decisions, little decisions, everyday decisions that also has to do with this political dimension. The decisions that we make when we decide to talk about a subject or not to talk about this, or if we are a teacher and we decide to give our children some material or some issue or not to give it, they are political decisions behind this. I hope you understand my proposal. And in this, when we think about this, it's more easy to see ourselves as members, as part of the communities. We were talking during this morning about communities, about what we expect from them. And it's time, I'm not saying this to you, but it's a reflection. It's time to think ourselves as part of the community. Sometimes we ask people, these other people, things that we never would do, or we don't do with our lives, and we have this this way of thinking. Academy people, like people from another world. Yes. So that's why I am trying to say all of these reflections and most of the things that you were talking about before me I think they are. I was thinking about this before. Their way, it's an invitation of think ourselves as part of these realities, not the keepers of the solutions or the keepers of the knowledge, but part of these realities. And as a puzzle, if we don't have all the pieces, we don't have the whole image. That's the invitation of thinking about this from this metaphor. Yes, and when we think things like this, we see that this puzzle model has a first limitation. A puzzle only, you can make a puzzle only in one way, and pieces have their limits, and reality is not like this. Reality is complex. Things are combined in a dynamic process, and that's why when we talk about Chagas like a kaleidoscopic puzzle. I hope you understand this. If not, it's in Spanish. Imagine in English. And yes, imagine that's when if we were in the same room, I will show you my little kaleidoscope to help me to understand or to explain this metaphor. But the metaphor is saying us to think about all the richness that every little color bead give us in the image that we see in a kaleidoscope. That is not the same because a kaleidoscope is dynamic. I will not see the same image that Mario see if I give him the kaleidoscope. But these images, the richness of these images will be result of the little bits of the little colors that each piece of the kaleidoscope gives. And I invite you to think about these pieces, like, for example, the different disciplines that can talk about the problem, or the different social actors that are involved in some problem. Are you following me, or I am? Yes? Thank you. And that's why with all of this in our minds, 10 years ago, we are commemorating, celebrating 10 years of work this year. We start asking ourselves, really, what do we talk about when we talk about Chagas? That's why we have this strange name for a group. We have a name of a question as name, but it's a question that give us the idea that we will never have an answer. We will need to question ourselves all the time, and we invite you to do this. It's good to do this exercise. Really ask ourselves, what do we talk about when we talk about Chagas, dengue, chikungunya, malaria, and try to give the more complex and complete answer. Is a really challenge, but it's the way we see that we must keep going. We will never reach this answer. And from our group, from this point of view, from all these 10 years, and I hope for longer time, we face our activities from research, training, university extension. I don't know if it exists in English. Extensión universitaria. It's a kind of work that people in university do outside the books and the class. Being in more contact with communities and society. Also from public communication of science activities, and also from activism, and also from learning. We learn every time we have an idea. We learn from people who we talk about this idea, or with who we materialize this idea. our point of depart, it's a critical point of view of the academic and the scientific formation. They, at least in Argentina, when you study biology, or when I studied biology a long time ago, I had the idea that I knew everything that anyone has to know about Chagas. And you know that it is not true, but in our university, sometimes they wanted to let us think like this. So from this point of depart, it's one of the basis of our work to seek all the things that that will help us to shorten this great distance, the distance between laboratories, universities, and society and people affected by Chagas. Another mantra we have. I bring these authors with me. I don't like. These are like my posters. I don't have posters in my office, but these are like the mantras we have and repeat and try to keep alive in our work. And the other one is this reality, this situation that let us know that scientific knowledge, it's only one kind of knowledge. It's only one of all the knowledges that we need and we use in everyday life. And that's why we, from our start, we incorporate the support and the things and all that arts and artists have to give for a subject like Chagas, because in Chagas we have a very, 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 very dark discourse, a very dark. Chagas is full of this disease of the poor, muletilla. I don't know the word in English, but it's plain of these dark, words. And Chagas is part of the life of people. And as part of the life of people, for example, artists have a lot to say. And we are convinced that with a song, sometimes you are able to invite more people than with a horrible picture of a kid suffering. That's why I use in all my presentations and almost all the drawings of our book. That's the moment when I start looking like a seller, but all of this is free. You can download from free from our web. But it's very important. We always like to talk about, for example, Carlos Julio, the man who made the drawing for our book, because we think that their drawings are as important as the words we try to put them. Also, in our work, we work a lot with drawings, with literature. It's an example from another book we made with little stories made by teachers and drawings from different artists. Each year we invite an artist to draw postales, tarjetas, cards. Different cards that we made each year and we give from free to people that come to our activities. And well, I have a lot of things an experience to tell. I wanted just to make this crazy thing and keep open to questions or invite you to our network and follow us and talk with us and use our things if are useful for you and give us your feedback we are always trying to learn. Thank you very much.